more people are joining, but in the meantime, well, this is a teaching point and recap VMR that well, our team, especially Irene, Leah, and Noah, have prepared one case recap and recapitulation of teaching points. Before starting, I've seen a few people that I don't know if they're just here for the first time or not. But I'm going to share my screen for a second. So you can all see this my screen, right?
Yes, we can see it.
So for the new people here or the ones that have not participated so much, this is a way that we in City Solar's team are preparing for the people that would like to show and present any case. You can email at this Gmail, and we can show you or guide you a bit how to present a case, and well, this would also be attached to your CV. So well, we all think that's a good opportunity, and if anyone is interested in presenting a case and wants to do it, but don't know how much or how can he or she could do it, we are here to help you. So just email this address and we'll help you. Okay. So let's see, how can I don't know, Ravi, could you return to the
Okay, so I think Noah or Leah, you can either share your screens now and begin your presentation.
Do you want to start, Leah, or should I?
However you want. I can go ahead if you want.
It's up to you.
All right. So then I will start. This is a new format that we're trying out. We're kind of recapping teaching points, getting cases back to get some deeper learning and also some spaced repetition, and just get the advantages of reflecting on cases back again. And I will share my screen. I prepared a short presentation. I think, David, you just have to unshare your screen. Oh, no, it's possible. Okay, it should work. All right. Can you let me know if you can see my screen? Okay, perfect. So the case that I will be recapping today is the case from last Friday, which was a really interesting one in many ways. And I copied the problem representation just to kind of remind each of us what the case was about. So it was a 39-year-old female from Mexico, presented with progressive, painful red eyes, and had also pain with eye movement and reduced vision. There was bilateral papilledema and headache also associated that we found out in the progress, or in the journey. So this is the problem representation. Lots of eye, I think, lots of things that make us clue into the eye. And I think eye, it's not, depending on where we practice, might be something where what we see commonly or not. But it's always good to have a kind of first approach. What are our first thoughts when we see an eye issue? And as with every kind of issue, if we have abdominal pain or something else, it's always good to just know what the red flags are. Also with chest pain, we do that. What are the red flags that we have to rule out, or that might make us think, oh, now we have to be careful. So while I continue, feel free in the chat to just share your ideas on what might be red flags for you when it comes to eye issues. And now I will share a few thoughts or approaches that came up in the discussion. When we have an eye problem, we can think about, is it a surface issue or is it a deep issue? We might also think of outside versus inside job, which kind of reminds us of our approach to rashes, where we heard that approach as well. Is it something that is outside, or is it a systemic condition that comes from the inside and leads to the eye issue? And then it's kind of similar to surface versus deep, is the anterior versus the posterior segment of the eye. And now, why is that important? Because maybe deeper issues might have different approaches, or might make the differential different if we can already kind of differentiate from the symptoms, whether it's a deep or a surface kind of issue. And I will just look into the chat for answer for red flags. And I love, Hans mentioned pain with eye movement, headache, vision loss was also mentioned. A glaucoma is definitely also with acute glaucoma is an emergency. So blurred vision, great thoughts there. I will share, feel free to share just thoughts as we go. But I will just share a few of the thoughts that were mentioned in the discussion. We said if there's no discharge, this might be concerning, because discharge, we associate that with surface issues. And if that is lacking, this might make us think, oh, maybe the issue is deeper, which might be more concerning. Also, if we have a red eye, which was the case here, where is the redness? Is it more central, or is it more in the periphery? And if it's more central, then we might think more of a deeper problem, so like anterior uveitis versus peripheral, maybe conjunctivitis issue. And then also, is it recurrent, or are there systemic symptoms, which might make us think of a systemic disease as well? And because I don't know how it's for you, but for me, it's always very confusing to get the terms for eye problems right and understand what it means. So I just want to take some time to recap structures of the eye. Now, let's make it very simple. Say 3 layers. The outer layer, the fibrous layer, where we have the cornea. Can you see when I show something on the screen? Yes, perfect. Cornea, and then also the sclera, which is fibrous tissue. We don't really have much vasculature going on there. So layer 1. Layer 2, here we have the choroid, so uvea, ciliary body, iris, which are all parts of the uvea, which is very highly vascularized. And then inner layer, the retina. And as you might figure, all of these fancy terms for inflammation of the eye comes from all of these anatomical structures. So here's a list of some of the things that I came up with, or not came up with, but thought of, and that were also mentioned in the discussion. And I just want to, because I think understanding these helps with so many different eye cases, that I think I just want to take time in this reflection to just discuss what these terms actually mean. So blepharitis was mentioned as one of the benign causes of red eye, or more benign. And it's when there's inflammation of the inner layer of the eyelid, or where the eyelashes start. So blepharitis. Conjunctivitis, I will just show it here. It's not labeled on this image, but it's the layer closing after the cornea, but still on top of the sclera. Conjunctivitis. Common causes are viral, bacterial, allergic. Then episcleritis, which is a thin layer above the sclera but below the conjunctiva, I believe. Not 100% sure, but it can also be inflamed and then have red eyes. Then scleritis, which is this outer layer that we mentioned. Uveitis. And now, here's my question to you again. What kind of terms do you know about uveitis? What other, I see some clues were already put in the chat, but what other names can you know how uveitis might be called differently? Because there are several terms for that. But if we look back here on the image, uvea, there's an anterior part, the iris and the ciliary body, and then there's a posterior part here. And an anterior uveitis is when we have iris and ciliary body inflamed, and posterior when we also have the choroid retinal parts. So keratitis, when we have cornea involved, or yes, irritated. Retinitis, when the retina, and then optic neuritis here with the optic nerve. So this is just a recap to help us understand the terms. And yeah, in the chat, you basically already nailed it way before I asked the question, David. We had anterior uveitis, iritis, how do you pronounce it in English? I don't know. Or iridocyclitis. Oh, these are hard to pronounce. Okay, and then we have posterior when it's chorioretinitis there as well. But I hope this was helpful to kind of understand some of the terms, and this will help us hopefully understand the findings in this case as well that we had. So we remember, we come back, we have surface versus deep issue. We have outside versus inside job. We have anterior versus posterior. Now, these are just frameworks that can help us start somewhere when we think about it. And something that is also really interesting in general, I think, is when we have a red eye, we see it from the outside. So maybe more the anterior part is involved, versus when we have something posterior, we might not always see it when we look at the patient as an examiner. So if it's a posterior uveitis, you might not get a red eye or see anything there. Versus if we have redness, this cues us in for an anterior segment issue. And then, now, I'm not sure whether you agree with me on this or what your opinion is. Please feel free to share it in the chat. But the discussion also, it was mentioned that when we have vision loss, this indicates more a posterior segment involvement because of the retinal layer and the nerve that is affected. Now, maybe you can think of parts of the anterior part of the eye that might also cause vision loss. Feel free to share that. But maybe it can just help us say things that are more likely for the posterior part and help us to start somewhere. I think in the end, we will need an ophthalmologist anyway. But yeah. So these were the findings of our patient. We had the injected sclera or in conjunctiva bilaterally. So again, something we see from the outside, redness, anterior part. Then we had bilateral optic disc edema, which is more posterior. We saw this on fundoscopy. And then there was also this very particular finding on OCT, that was this fancy imaging modality we had for the eye, which was isolated bilateral serous retinal detachment. And now I had never heard of this finding before, but together this with bilateral panuveitis was kind of a buzzword, or would be a buzzword for all of those who've already heard of this unpronounceable disease, which is the EKH disease. And so what is this? It's quite a rare disease, which is one of the B syndromes, so BEE, brain, eye, ear syndromes. And it's a CNS disease that can cause eye issues. Typically this panuveitis, and we learned what is the uvea. So panuveitis, not just the anterior, but posterior. Usually all of the uvea is affected. And it can cause this bilateral serous retinal detachment. This fits in with the vision loss our patient had. And ear, that's the second E, ear problems can be present as well. And it's maybe what was significant in this patient here, we had mostly the symptoms revolved around this area. So we had eyes, headaches, so brain, CNS maybe, with the retinal involvement, but not really anything else. And this is kind of a particular pattern or involvement, and it's a rare disease. But I think there were so many teaching points on just how to approach eyes in general and review a bit of the anatomy. So this was my short recap of the case. I hope it was helpful. I definitely learned a lot by revising just how the eye is comprised. And I'm not sure how much I managed to follow the chat while we did this, but I'll stop sharing my screen and I'm excited to hear our next recap.
Okay, thank you, Leah, so much for this recap and for going for some of the basic aspects of uveitis and redness. I think in the clinical practice, most of them forget after learning ophthalmology a bit in the university. So now Noah is going to talk of another case. Noah, you can start when you want.
Hey everyone, my name is Noah. I'm a CP Solvers team member, and today I'm going to be talking about the case we had on a student VMR presented by Ibrahim about shortness of breath. So this is the whiteboard. I redacted some information because I'm not sure if everybody watched the VMR. I'll participate in the VMR since it's not recorded, and I wanted to keep the suspense. But I did put up a problem representation with the most pertinent information. So he had a previously healthy young woman with a family history of early sibling death that presented with chronic, persistent, progressive dyspnea associated with dizziness, orthopnea, palpitations, and hypoxemia with a largely unremarkable physical exam. Now, I want to dissect this problem representation and extract the most information we can get from what we have so far. So, piece by piece, a previously healthy young woman, shout out to Rebecca Berger, that gave us this amazing framework of bad genes, bad luck, bad environment, and risky behavior. In this case, there is one key piece of information in her history that points us towards one of those four causes, which is the early sibling death. So we're thinking more of genetic causes to this early presentation. Now, the chronic persistent progressive dyspnea. Dyspnea has a very, very wild differential diagnosis. And we have the dyspnea pyramid. We have this amazing schema in the CP Solvers website. And that's where descriptors come in to help us guide this differential diagnosis. So being chronic means something. Being persistent means something. Being progressive also means something. Let's say we think it's asthma. Asthma is not usually persistent. We have bouts of inflammation and bouts of shortness of breath. Being persistent then helps us put asthma further down in our differential diagnosis. The orthopnea also helps us, but it can also misguide us if we don't have a very clear understanding of what the pathophysiology of orthopnea is. When I was watching the case on Sunday, I was in my mind, orthopnea means heart failure. That was the only association I could think of. But if you think about it, orthopnea basically means that when you're laying down, you have more shortness of breath. And what happens with your body when you lay down? You have less gravitational effect, more venous return, more pressure in the pulmonary capillaries, and more edema or other causes that cause shortness of breath that worsen with a higher pulmonary capillary pressure. So orthopnea basically means that you have shortness of breath when you have elevated pulmonary capillary pressures. The most common example, of course, is heart failure with pulmonary edema, but as we will find out, there are more causes for this symptom. And it's not very specific, it doesn't have a very good likelihood ratio either. Dizziness. Dizziness, it's hard to really dig in, but we can assume in this case it's a pre-syncopal event. She got dizzy when she was exerting herself. And when we activate the syncope framework, we know that syncope basically means decreased cardiac output or decreased resistance. If she had syncope during exercise, we can infer that she had syncope in a state that required her body to have a higher cardiac output. So this helps us, this brings us to this part of the schema, decreased cardiac output. And then we have cardiogenic causes or hypovolemic causes. Since this was going on and we had no signal for hypovolemia in this patient, we stick with cardiogenic. And the causes are aortic stenosis, hypertrophic obstructive cardiomyopathy, PE, pulmonary hypertension, and pericardial disease. So bringing those two complaints together, we see that this Venn diagram of chronic dyspnea and pre-syncope can help us narrow our differential diagnosis to these four entities. It's not a like exhaustive list of potential diagnoses, but those are the most likely ones. Now, this patient could obviously have multiple diseases that are causing multiple symptoms. Or she could have one single disease that was causing complications, and those complications were manifesting as symptoms. However, she was previously healthy. She was very young. The physical exam was largely unremarkable. So that leads us into thinking that she had a disease that was causing those multiple symptoms at the same time. I'm not sure if my reasoning is very clear on this, but basically, we didn't have a signature for a very extensive disease process. She also had hypoxemia. So hypoxemia means a problem with the alveolar capillary gas exchange, basically. And we'll come back to that later. So let's take a breath and think, what wasn't sitting right with me during this discussion? I was thinking more pulmonary hypertension. And if so, why did you have the hypoxemia? Because pulmonary hypertension, you don't usually see hypoxemia because it's a problem with the resistance of the arterioles. We don't affect the gas exchange unless we have an intracardiac shunting from right to left and mixing deoxygenated blood with oxygenated blood. If she had pulmonary hypertension, why didn't we have symptoms of fluid accumulation, of RV overload, of RV failure? Then let's move on to my second diagnosis. If she had aortic stenosis, why did she have hypoxemia? Unless she had pulmonary edema. But if she had pulmonary edema, wouldn't we hear it as crackles? So what would you expect to find in the chest X-ray, in the CT chest, in the echo, and in the spirometry? You have to at least think of possibilities because this will help you interpret the findings after you get the exam. What we found was hilar lymphadenopathy with interstitial markings on bilateral lungs. We found an intracardiac shunt, although it wasn't right to left, it was left to right, so most likely a bystander. Mild pulmonary hypertension and a small left atrium. On the CT chest, no filling defects, diffuse ground glass nodularities, and on the spirometry, a low capacity for diffusing carbon monoxide. So let's update the problem representation with the thoughts we had and with the exam findings. We had previously this one, and now I translated that to this. So we have a woman with probable genetic disease causing pulmonary hypertension, as seen in the echo, and the pathophysiology checks out too. That's worsened with pulmonary capillary hypertension. So that's the orthopnea talking. We have issues with the alveolar gas exchange as well, and we have lymphadenopathy. And those questions are some questions that were going on in my mind. Would pulmonary arterial hypertension behave like this? meaning would pulmonary arterial hypertension worsen with capillary hypertension? I researched this. It's not the most common presentation, but it's possible. It's most commonly associated, orthopnea, with pulmonary venous hypertension. The gas exchange problems comes from the low diffusing capacity, and the lymphadenopathy, my differential for this was inflammatory, reactive, or malignant. Those were the main causes of lymphadenopathy, hilar lymphadenopathy in my mind. And I was thinking, maybe this woman has sarcoid. I didn't know how to interpret those findings because I had a knowledge gap about what the lymphadenopathy meant. So let's find our problem. We need a disease that's exactly like this. And lucky for us, we have one disease that's exactly like this. It's called PVOD, pulmonary veno-obstructive disease. So it's a disease that proliferates the capillaries in the lungs. We have pulmonary venous hypertension. We also have problems with the gas exchange, as we have histopathological changes in the alveolar spaces, which explains the hypoxemia, explains the pulmonary hypertension. And what about the lymphadenopathy? Well, this is for the next slide. So PVOD, lymphadenopathy with a normal or a small left atrium, can represent pulmonary venous congestion. So when you have pulmonary venous congestion, the fluid has to go somewhere, and the lymph nodes are prime space for the fluid to accumulate. This caveat of a small left atrium is because aortic stenosis can cause also lymphadenopathy, but you would see an enlarged left atrium in this case. Severe hypoxemia and pulmonary hypertension should prompt the evaluation of shunting and PVOD. And this is actually something that I didn't come up with. I actually found this exact quote in an article. So what wasn't sitting right really wasn't sitting right with her presentation. Low DLCO and hypoxemia in pulmonary hypertension should raise the suspicion for this entity. Cutoffs for how low and how severe the hypoxemia are not established yet because this is a very rare entity. And finally, the clinical diagnosis is based on hemodynamic findings of pulmonary hypertension and CT findings of venous congestion. So septal thickening, ground glass opacities, and lymphadenopathy. In the past, we relied on histopathological diagnosis, but nowadays experts consider that a clinical diagnosis is possible given those conditions. Those are the images and references.
Oh, thank you so much, Noah. Well, if anyone wants to share his thoughts or her thoughts, is welcome. But I learned a lot with your presentation, and thank you so much for remembering us the pathophysiology and explaining more the features of PVOD. That is not a common disease, but you explained that the pathway to the diagnosis very well, and thank you so much for doing it. Well, we're moving towards evening presentation, and we will let a minute at the when we finish for any thoughts if you want. So Ibrahim, go for it.
Okay, so today I'll be touching back on a derm-focused Rafael Medina VMR that we have had recently. This was a presentation of a skin rash. So typically, the session had started with these two images in here. And I feel that one of the first things that we should touch point on is the fact that how would you go on to describing both of these bilateral skin lesions that we can see in here. And so typically, if you have a patient who is presenting to you with dermatological manifestations of a systemic disease, you should first be thinking about whether or not this patient is sick or well. The reason why you would first be considering whether they're sick or not is because typically dermatological manifestations with severely sick patients require a prompt diagnosis as well as prompt consultation from a dermatologist. Another point as well is that you would be describing the morphology of these skin lesions in here. And so the most important things that relate to medicine is really vasculitis when it comes to dermatological manifestations. And so typically you want to know whether these are purpura or not. And the way by which you can say or tell whether these are purpuric skin lesions is that you can close your eyes and you can run your fingers on these lesions. And if you can still feel them, even though you're closing your eyes, it means that most likely these are purpuric. And then another important point as well is that you want to describe the progression of these lesions. So it's not just enough to say that these are bilateral purpuric lesions, but it's also important to ask the patient whether this was their first time having these lesions or whether they have had them before and now they have progressed into this picture. Another important point as well, because vasculitis is all about recognizing systemic symptoms, is to ask the patient whether or not they have any comorbid conditions. So things like, for example, asthma or sinusitis can clue you into one type of vasculitis rather than the other. Another point as well is that you need to ask the patient whether or not they had recent medications or recent viral infections. And this was an important point that I learned during this VMR, is that sometimes you can have vasculitis secondary to viral infections. And typically once these viral infections resolve, you're no longer going to see the dermatological manifestations, as well as with medications. And so this is the whiteboard for the recap session for the VMR session that we've had. This case was presented with Dr. Asma Zaidan, and the patient ended up having something known as eosinophilic granulomatosis with polyangiitis, which I'm sure a lot of people in here are already familiar about with this disease. And so if you can look into this whiteboard, you can see that there are specific points that you can look into and get the diagnosis without further examinations. So things like sinusitis, things like, for example, this patient also on spirometry had obstructive pattern with reversibility, indicating an undiagnosed asthma. And so with the dermatological manifestations typical of vasculitis, you could very much well say that this patient had eosinophilic granulomatosis with polyangiitis. However, an important point that you need to consider is that for vasculitis, you have to actually confirm, except for one diagnosis that I'm going to show at the end. You don't need a biopsy to confirm the diagnosis. However, for almost all types of vasculitis, you typically have to get a biopsy in order to actually confirm your final diagnosis. And so an introduction about vasculitis in general. We often think about vasculitis as a systemic disease that actually affects different organs. And then the dermatological manifestations are secondary to that inflammation. However, this is not always the case. Sometimes vasculitis by itself can be a skin-limited condition, so it can only appear on the skin. Sometimes it can be a primary cutaneous vasculitis and can have secondary systemic involvement. And sometimes, as most of people in medicine would see, usually the cutaneous manifestations can be secondary to a systemic vasculitic process. And another important point is that the skin manifestations that you see depend on vessel involvement. So we're usually taught that, you know, whenever you have vasculitis, you will see the non-blanchable purpura, and those will tell you that this patient has vasculitis. In reality, vasculitis can have wide presentations, and the presentations depend on the vessels that are being involved. Are these large vessels? Are these medium vessels? Are they small vessels? So large vessels are things like the aorta. So things like Takayasu's arteritis, things like GCA, those would be large vessel vasculitides, and typically they would not present with any dermatological manifestations. However, when it comes to medium vessel and small vessel vasculitides, then the variability in dermatological manifestations comes into place. Medium vessels are vessels that typically supply blood to the organs. So things like the renal arteries, for example, and small vessels are vessels that end up within the organ itself. So for example, vessels that you would see in the dermis of the skin, these are small vessels. And so whenever you see these lesions, you should typically think about small vessel vasculitis, and I'm going to explain each of these. So when it comes to palpable purpura, which we had just seen in this patient, you would typically think about small vessel vasculitis. However, if you cannot feel the purpura even though you're closing your eyes, this does not necessarily rule out vasculitis entirely. So if you still have a high clinical suspicion, however, the patient is presenting with macular purpura instead of palpable purpura, this could still be small vessel vasculitis. Another presentation could be urticarial papules in here, and papules are elevated skin lesions. Typically, those would itch. And so if a patient is presenting with such a picture, you should also be thinking about small vessel vasculitis. And then for pustules, some patients can also present with pustules secondary to vasculitis, and these would typically be small vessel vasculitides. And for small vessel vasculitis, patients can usually present with something known as livido-racemosa. They can present with retiform purpura, and they can present with subcutaneous nodules. So usually we're taught in medicine about livido reticularis, but we're not taught that much about livido-racemosa. And they look fairly similar, but the way by which you would actually differentiate livido reticularis from livido-racemosa is that livido reticularis, the vessels would actually be connected to each other. However, in livido racemosa, in this picture in here, if you look at the vessels closely, you can see that there are some spaces in between the vessels, which kind of make them seem disconnected from each other. So if you see something like this, you should be typically thinking about livido racemosa. And then for the retiform purpura, retiform basically means net-like. And so if you see a net-like vascular involvement on the skin this way, you should be suspecting medium vessel vasculitis. And then finally, the subcutaneous nodules, because the medium vessels are much more lower in the subcutaneous part of the skin in comparison to the small vessels, which can reach the dermis, you can have hemorrhage underneath the skin, and this hemorrhage can appear as subcutaneous nodules. Another important point as well into how we can have different dermatological manifestations, and these different dermatological manifestations will depend on vessel involvement, is when it comes to biopsy. So typically the biopsy that would be used to diagnose something like vasculitis that's appearing on the skin would be something like bunch biopsy. And if you have seen a bunch biopsy before, it goes all the way into the skin itself. So you don't just want to go into the dermis, because then you will miss the subcutaneous. And if you miss the subcutaneous, you won't be able to see the inflamed vessels, medium sized vessels that are in the subcutaneous. And so a bunch biopsy will reach all the way down to the skin, and we'll be able to get most of the vessels reaching that area. And so typically as a PCP or primary care physician or someone in internal medicine, your approach to rashes should be whether the patient is sick and whether or not these are painful or painless rashes, because these would be highly concerning. And if you ever see those two things happening in a patient, you should consult dermatology immediately. You should review recent medications as well as viral infections that the patient had, because sometimes they can result in dermatological manifestations. And then if you're suspecting hives, which I think a lot of physicians see in the hospital, there is a way by which you can actually confirm whether or not this patient has hives or morbilliform rash. And the way by which you would differentiate hives from morbilliform rash is that you would draw around them, and then you would review this rash in 24 hours. If these hives are enlarging, most likely they're hives. If they're not, it means that most likely they're morbilliform rash. And then there's also another way by which you could confirm this, is that you could use an end of cotton wool applicator, and then you could scratch the area where the patient is presenting with the skin manifestation. And if there's dermatographism, and dermatographism basically means that if you touch that area where you scratched it, you're going to feel that the skin becomes elevated. This means that most likely this is hives as well. And then if you suspect Stevens-Johnson syndrome or toxic necrolysis, you should consult ophthalmology and gynecology, which is something I didn't know, right? So even if you actually treat a patient with Stevens-Johnson syndrome, a lot of these patients will have long-term ophthalmological as well as private part complications. However, if you recognize them from very early on and involve ophthalmologists and gynecologists, you might be able to prevent these manifestations from happening. And you also need to ensure full examination, focusing specifically on mucosal membranes. If on bunch biopsy, which we've already discussed, you see something like granulomas, you should be thinking about something more chronic. And so do not think about vasculitis secondary to infection or secondary to medications, but think about vasculitis that's happening secondary to a syndrome. And then when you describe the rashes, just like we've mentioned, you have to describe them as whether or not they're painful or painless, if they're itchy, the morphology, the sites, the prior episodes that the patient had, the onset and the progression, as well as the systemic manifestations and systemic comorbidities that the patient might have. And so in vasculitis, this is going to be a very prompt review. All what you need is pattern recognition. So in things like polyarteritis nodosa, you would see abdominal pain, skin ulcers, neuropathy. And GPA, you'd see pulmonary renal symptoms, upper and lower respiratory tract, PR3 ANCA. In microscopic polyangiitis, you can see pulmonary and renal symptoms. You can see myeloperoxidase ANCA. And so the list goes on and on. I'm not going to go over it entirely because I think it's going to be boring a little bit. And then there are different vasculitides other than the syndromic ones that we're usually taught. And these are hard to classify. They're different from the usual ones because they present with different organ involvement. And sometimes they can have mimickers to these vasculitides, but if you have them within your differential, you shouldn't miss them at all. Those include things like IgG4 related systemic disease. They include things like Cogan syndrome. And Leah has talked about the brain and ear and eye syndromes. And this is one of them actually. And you can also have primary CNS vasculitis, intestinal vasculitis, chronic periarteritis, thromboangiitis obliterans, which will typically occur in males who are also smokers. Mimickers would be things like atheroembolic disease. So a patient who recently had a CAT could be presenting with digital necrosis. However, if you don't ask about comorbidities or whether or not the patient had a recent CAT, you may miss this mimicker. And this is where the comorbidities come into place, really. Cardiac myxomas, thrombotic diseases, including antiphospholipid as well as TTP. And there are also certain medications, just like we've mentioned, including cocaine, amphetamines, and ergot derivatives. And finally, infective endocarditis. So we'd be ending with 2 questions, and I'd love to see if there are people who can actually help us, who can guide us through these questions. So supposedly you're in the ER and there is a 38-year-old male who's presenting with long-standing asthma. And they're now presenting with palpable purpura, diffuse abdominal pain, fever, and worsening dyspnea. And this patient was recently started on a leukotriene antagonist. Their WBC count is 18,000, and on WBC, they have 25% eosinophils. So what to do next? Here's are the choices. So let's see if there is someone who can help us answer this question. So A would be increase inhaled steroids. B, begin plasmapheresis. C, increase prednisone from 10 milligrams to 20. D, begin IV steroids. And E, perform an open lung biopsy. Okay, so maybe okay. So Noah is going with D, begin IV steroids. David is going with D, Hans is going with B. Okay, so Diaz is going with C. Ashutosh is going with IV steroids. Okay, so I can see that a lot of people are choosing IV steroids, which is actually the correct answer. The reason for that is that this patient is actually, right, so yes, so this patient was actually, is having eosinophilic granulomatosis with polyangiitis, and they're presenting with diffuse abdominal pain. So diffuse abdominal pain is what should clue you into the answer. The reason for that is that if you remember, we mentioned that vasculitis can be a systemic process. So even though this patient is has presumably eosinophilic granulomatosis with polyangiitis, vasculitis does not really differentiate and can affect any different organ in the body. So sometimes you can have intestinal ischemia secondary to the vasculitis, which can have a really huge impact on the patient if their case deteriorates. And so typically you would want to start them on IV steroids. Okay, so thank you everyone. So the second question is, this is a 79-year-old female with diabetes. She's presenting with 2 weeks of headache and neck pain, 2 episodes of transient blurred vision. On physical, she has, her scalp is diffusely tender, range of motion is limited due to shoulder pain, normal vision and reflexes. CK is 150 and she has normal ESR and CRP. So what to do next? So the choices are head MRI, B is EMG, low dose prednisone, high dose prednisone, Doppler ultrasound for the carotid, or temporal artery biopsy. So let me check the chat. Okay, so a lot of people are saying D, high dose prednisone. Exactly. So that's actually the correct answer. You would go for high dose prednisone because granulomatosis would GCA, sorry, can result in acute vision loss, which is typically non-reversible if it happens. And so you typically want to treat the patient with high dose prednisone and then take them for a temporal artery biopsy at the end. So this was the end of my case. So thank you, everyone.
Oh, thank you so much, Ibrahim. Just a great recap. I especially like the dermatology, different kind of involvements in rheumatic diseases and vasculitis. And thank you so much also for incorporating the questions at the end. That I think is a great way to improve our knowledge. I'm just asking if anyone wants to share his or her thoughts. In the meantime, I mean, I'm sharing just one reflection for me in every case. In the case that we have presented, one teaching point that I would also make when approaching an uveitis is trying to differentiate if the patient has only ocular symptoms or has also any kind of systemic symptoms. In the systemic bucket, there are a lot of infectious, autoimmune, and also other kind of diseases. But there's a great way to point towards one diagnosis if the patient has any other systemic symptom. In that case, you can remember that the patient also had like hearing problems. I don't know if exactly that were tinnitus, but in both Koyana and Harada, there's this kind of involvement, and this could be a clue to the final DX. Another reflection for the case that Noah presented that I like a lot is what Seema talked about in the chat. In this case, there's you can approach it in different ways, but I would do it what Seema just pointed. Let me see for a moment. She said she remembered that PVOD behaves like right heart failure, but looks like left heart failure on the chest X-ray with the interstitial edema mimicking pulmonary edema. Another teaching point here is that I struggle with the case is the presence of lymphadenopathy in the CT. I think we are not too much accustomed to see lymphadenopathy in a case with primary heart or arterial or venous pulmonary arterial or venous involvement, because we don't do a lot of CT chest in this kind of presentations. We only do X-ray, at least in my setting. But there's also that possibility that Nora talked of the lymphadenopathy being reactive to the fluid overload. There is one that you have to take in account, and not confusion so much with other inflammatory and infectious possibilities. And well, finally for the case Ibrahim talked, I liked a lot and will review his explanation on the different types of skin involvement. Especially, I didn't know that differentiation between livedoor racemosa and livedoor reticularis. And I think another great thought and that I will keep in my mind is the necessity of doing a biopsy that also goes to the subcutaneous tissue to try to see if there's an involvement there that could point towards medium vasculitis instead of small vessel vasculitis. There's just a bit recap of all the cases, but if anyone else would like to share his or her thoughts, would love that.
Yeah, I just wanted to answer Rob's question regarding the normal ESR and CRP in patients with GCA. So ESR and CRP, as a lot of you know, actually change based on the age that the patient is presenting with. So elderly patients have higher levels than patients who are usually younger. And because GCA usually happens in elderly females, typically, so the ESR and CRP range would be typically higher than the other middle-aged population. And this is why it's thought that typically these patients present with normal ESR and CRP. However, almost all of the cases would be presenting with an ESR and a CRP that's greater than 15. Typically, the ESR would be greater than 15.
Amazing.
Cool.
I just have one quick thing I want to say because I actually completely forgot to say, but I thought it was really, really interesting. So I just want to share it in the end. But we talked about pain with eye movement. And in the discussion, it was said that it can clue us into optic neuritis because the optic nerve, how the meninges are wrapped around it. And if it's irritated, it moves or it's painful with eye movement. And then when I was reading about painful eye movement, I also found out that scleritis can also be painful with movement because you remember it's the most outside layer and the muscles insert, the eye muscles, the outside eye muscles insert into the sclera. So that's why it can also be painful with movement. And I just thought that was a cool thing and I didn't want to leave you without that information.
Thank you so much, Leah. I didn't know that, and that's a great pearl. Well, before leaving, I will share just my screen once again for the people who are listening here or who listen after in YouTube or anywhere. You can see what if anyone has missed what we said at the beginning of the session. If anyone would like to present a case or thinks that he or she has a case that is interesting, we could help you to present it here. And I think well, this is a pretty good environment for starting to do presentations because the team is amazingly helpful with all of this, and it's a very very good environment for starting that. So would love to hear other people, and well, thank you all for being here, and we'll see you tomorrow.